Hi class, I'm Dr. Fife, and I'm going to cover the cardiovascular and lymphatic systems. We'll start with some structure and function of the cardiovascular system, function and delivery of oxygen, nutrients, hormones, cells of the immune system, and other substances to body tissues. And it's for the removal of waste products of cellular metabolism. The heart is composed of two conjoined pumps that power movement of blood through two separate circulatory systems. The right heart pumps blood through the lungs, and it's a low pressure system. And the left heart sends blood through the systemic circulation, so this is a high pressure system. Arteries carry blood from the heart. Capillaries allow exchange between blood and interstitial space, and the veins carry blood from capillaries back to the heart. There's three layers to the heart wall: the epicardium, myocardium, and endocardium, and it's enclosed in a double-walled membrane sac called a pericardium. Four chambers in the heart. We have right and left atrium and right and left ventricles. Atria have the thinnest walls, being low pressure. They act more as a reservoir for holding blood before sending it into the ventricles. And the left ventricle endures the highest pressure because it has to pump that blood out into the systemic circulation. We have valves that are for the one-way blood flow through the heart: atrioventricular valves, or the tricuspid and mitral, and the pulmonic and aortic or semilunar valves. We have great vessels: the superior and inferior vena cava. It's deoxygenated blood from systemic circulation. The pulmonary artery divides into right and left pulmonary arteries and transports unoxygenated blood from the right heart to the right and left lungs. The four pulmonary veins carry oxygenated blood through the left atrium and ventricle into the aorta. Blood flow during the cardiac cycle is in 5 different phases. We have coronary arteries. The major coronary arteries are the right coronary artery, or RCA, and the left coronary artery, or LCA. The RCA has greater flow than the left in about 70% of individuals. The left anterior descending, or LAD artery, delivers blood to portions of the left and right ventricles and much of the interventricular septum. Circumflex artery travels in a groove called the coronary sulcus and supplies blood to the left atrium and the lateral wall of the left ventricle. Collateral arteries, these are connections between branches of the same coronary artery, or connection of branches of RCA with branches to the left. The epicardium contains more collateral vessels than the endocardium. Coronary veins and lymphatic vessels. The great cardiac vein drains the anterior surface of the heart, and posterior vein of the left ventricle. This is largest on the posterior surface of the heart and branches from the coronary sinus and accompanies the circumflex artery and then joins the cardiac vein. So a little more on the valves. These allow for that one-way flow of blood through the heart. During ventricular contraction, the two atrioventricular valves open and blood flows from a relatively high pressure in the atria to a lower pressure in the relaxed ventricles. With increasing ventricular pressure, these valves close, and it prevents the backflow of blood into the atria. Semilunar valves open when intraventricular pressure exceeds aortic and pulmonic pressures, and blood flows out of the ventricles into systemic and pulmonary circulations. After ventricular contraction, intraventricular pressure falls, and pulmonic and aortic semilunar valves close when pressure in vessels is greater than the pressure in the ventricles. The AV valves, or tricuspid and mitral, their openings composed of flaps called leaflets or cusps. And we have papillary muscles that are extensions of the myocardium, and these help to hold the cusps together and downward at the onset of ventricular contraction, and this prevents the backward expulsion of the valves into the atria. Conduction system of the heart, we have the SA node, which is the pacemaker of the heart. This is located at the junction of the right atrium and the superior vena cava. It's nourished by the sinus node artery, and it's heavily innervated by the sympathetic and parasympathetic nerve fibers. Impulse formation is by spindle and spider-shaped cells, and we have 60 to 100 action potentials per minute from the SA node. Action potential travels atrioventricular node to the bundle of His and through bundle branches to the Purkinje fibers in the heart wall. Right bundle branch is susceptible to interruption by damage to the endocardium, and the left bundle branch damage to aortic and left ventricle, aortic valve or the left ventricle can interrupt the left bundle branch. Cardiac innervation, the autonomic nervous system influences rate of impulse generation, depolarization, and repolarization of the myocardium, and strength of atrial and ventricular contraction. Autonomic neurotransmission produces changes in the heart and circulatory system faster than that of metabolic or humoral agents. And you think of this as the fight or flight, it has to work fast. Sympathetic stimulation increases electrical conductivity and strength of the myocardial contraction, and vagal parasympathetic nerve activity slows the conduction of action potentials through the heart, reducing strength of contraction. There's adrenergic receptor functions. We have 5 types. There's beta 1, 2, and 3, and alpha 1 and 2. And the cardiovascular structures have more beta receptors. Myocardial cells, we have fibers or bundles of myofibrils. These have a single nucleus. There's sarcomeres, which are dark and light bands of myofibrils comprise longitudinal repeating units. There's rapid transmission of electrical impulses from cardiac fiber to fiber due to a network of fibers connected at specialized intercellular junctions called intercalcated discs. Heart muscle cannot rest, so it needs a constant supply of energy, and this comes from adenosine triphosphate, or ATP. Okay, we have factors affecting cardiac output. The cardiac output is the volume of blood flowing through the systemic or pulmonic circuit and is expressed in liters per minute. Cardiac output is calculated by multiplying heart rate per minute by stroke volume in liters per beat. Normal adult cardiac output is about 5 liters per minute. Ejection fraction, ventricles do not inject all of the blood with each heartbeat. An ejection fraction is calculated by dividing stroke volume by end diastolic volume, and normal is about 70 to 80. Ejection fraction is a valuable clinical indicator of ventricular function. And there's 4 factors that affect cardiac output. Preload, which is pressure generated at the end of diastole. Afterload, which is resistance to ejection during systole. And myocardial contractility and heart rate, characteristics of the cardiac tissue, and are influenced by neural and humoral mechanisms. The Frank-Starling law of the heart, this is a length-tension relationship of cardiac muscle, relates to resting sarcomere length expressed as the volume of blood in the heart at the end of diastole, or the end diastolic volume, to tension generation. The volume of blood in the heart at the end of diastole is directly related to the force of contraction during the next systole. We have Laplace's law. Wall tension is related directly to the product of intraventricular pressure and internal radius, and inversely related to wall thickness. And this is useful for understanding aneurysm formation, distensibility in blood vessels, and effects of ventricular dilation on myocardial contraction. Heart rate, on average for adults, it's about 70 beats per minute. This is higher in children. Diminishes, goes down a little bit during sleep of about 10 to 20 beats per minute. And during activity can go up over 100 beats per minute. There's neural, hormonal, and chemical factors that influence heart rate. Neural, it's controlled by the CNS and ANS. Hormonal, there's catecholamines such as epinephrine and norepinephrine, and thyroid hormones, growth hormones, and endocannabinoids. Sympathetic nervous system increases frequency of cardiac pacemaker, and parasympathetic stimulation has a bradycardic effect, slows the heart down some. The vein bridge reflex, this is changes in heart rate that occur after IV infusions of blood or other fluids. Volume receptors in the atria that are innervated by the vagus nerve. And here's just some different factors that can have an effect on increasing and decreasing heart rate. Systemic circulation, there's 3 layers. In the vessels, tunica intima is the innermost, and this is a layer of squamous epithelial or endothelium, a layer of connective tissue, and a basement membrane. Tunica media or middle layer, there's smooth muscle fibers mixed with elastic fibers. Tunica externa, or the active layer of connective tissues containing nerves, lymphatic vessels that influence both vessel development and muscle tone. Now, adults can grow new blood vessels. It's called angiogenesis when there's the branching of small vessels, such as capillaries. Arteriogenesis is the branching of larger vessels, such as arterioles. And vasculogenesis, which is the growth of vessels from progenitor or stem-like cells that originate in bone marrow or other body tissues. Arterial vessels, connective tissue, fibrous connective tissue, and smooth muscle. And there's 2 types, elastic and muscular. Capillaries are composed solely of a layer of endothelial cells surrounded by a basement membrane. And veins are thin-walled and fibrous with a large diameter. And there's valves that regulate the one-way blood flow through the veins. The lymphatic system, this is a one-way network of vessels that is important for fluid balance, immune function, and transport of lipids, hormones, and cytokines. It filters out about 3 liters of fluid from the venous capillaries every day. It's a pumpless system. There's a series of valves that ensure that the fluids go one way of that excess interstitial fluid or lymph, and it goes towards the heart. Lymph is primarily water and small amounts of dissolved proteins, mostly albumin, that are too large to be reabsorbed. Lymph carries 2 types of cells, lymphocytes and antigen-presenting cells. Lymph flows slowly through a node, which facilitates phagocytosis of foreign substances with the node by antigen-presenting cells and entry of mature but naive B and T lymphocytes, waiting for a chance encounter with an antigen. Tests of cardiovascular function. An X-ray can be done if we want to look at the size and contour of the heart and the related structures. EKG can tell us information on the electrical conduction system of the heart, heart rate and rhythm. Echocardiogram, this is a most effective and widely used non-invasive modality for evaluating structures of the heart. You can do an echocardiogram to evaluate coronary artery disease, heart failure, valvular disease, endocarditis, cardiomyopathies, and congenital heart disease. Exercise or stress testing or examining the cardiac activity during exercise. And this elicits signs and symptoms of heart disease and coronary artery disease. Single photon emission computed tomography or SPECT. This is to evaluate for coronary artery disease and myocardial ischemia during stress testing. A CAT scan or MRI can be done to evaluate cardiac anatomy and physiology. Technetium scanning or radiopharmaceuticals are injected at rest during hotspot imaging examination. And 2 hours after injection, the distribution pattern is recorded by a nuclear scan. Electrophysiology studies, this is a more in-depth look at what's going on electrically with the heart, and this can provide information in nature of different dysrhythmias. Okay, so now we'll look at some alterations of cardiac function. We have a deep vein thrombosis. Thrombus is a blood clot that remains attached to the vessel wall. When it's detached, that thrombus becomes a thromboembolism. This is more common in the venous circulation than the arterial. DVT clot formation in the large veins, primarily in the lower legs. The triad of Virchow, these are three factors that promote venous thrombosis. Venous stasis, which can be caused by immobility, obesity, prolonged leg dependence, and heart failure. Venous endothelial damage from trauma or medications. And hypercoagulable states that can occur with inherited disorders, malignancy, pregnancy, oral contraceptive use, or hormone replacement therapy. Genetic abnormalities include factor V Leiden, prothrombin mutations, and deficiencies of proteins C and S and antithrombin. Thrombus formation often occurs near venous valves. Inflammation around the thrombus promotes further platelet aggregation, and a thrombus grows proximally. Increased pressure behind the clot can cause edema. Most thrombi that form dissolve without treatment. Untreated DVT, there is a risk for that clot to break off and become a thromboembolus and go from the leg to the lung, which of course can be fatal. These are often asymptomatic and difficult to detect clinically. We want to have prophylactic treatment for immobilized patients to help prevent DVTs. This can be diagnosed with a D-dimer and ultrasound of the leg. And treatment is going to be with some sort of heparin or other antithrombin agent. Hypertension, the consistent elevation of systemic arterial blood pressure. This is the most common primary diagnosis in the United States. It's estimated that 1 in 3 adults over the age of 20 have hypertension. And this is the highest amount of this is in Black adults, about 44% worldwide. About 80% of those with hypertension are unaware, and hence why it is known as the silent killer. It's defined as a sustained systolic blood pressure of 140 or greater and a diastolic of 90 or greater. Most cases are primary hypertension, about 95%, because there's no known cause for it. Secondary hypertension, about 5% of cases are caused by altered hemodynamics associated with primary disease. So there's some other disease process that's going on that's leading to the secondary hypertension. Primary hypertension, there are genetic and environmental factors involved, inherited defects associated with renal sodium excretion, insulin and insulin sensitivity, activity of SNS, and renin-angiotensin-aldosterone system, abbreviated RAAS, and cell membrane sodium or calcium transport. In Blacks, there's a variant of an apolipoprotein L1 or APOL1 that's associated with hypertension and renal disease. Risk factors for hypertension listed here: family history, age, gender, race, high dietary sodium intake, glucose intolerance or diabetes, cigarette smoking, obesity, heavy alcohol consumption, low dietary intake of potassium, calcium, or magnesium. And here on this chart is just some risk factors listed there as well. Hypertension is caused by increases in cardiac output or total peripheral resistance, or both. Cardiac output is increased by any condition that increases heart rate or stroke volume. And peripheral resistance is increased by any factor that increases blood viscosity or reduces vessel diameter, such as vasoconstriction. Primary hypertension, complicated interaction between genetics and environment that increases vascular tone or increased peripheral resistance and blood volume, thus causing sustained increases in blood pressure. There's multiple pathophysiological mechanisms that mediate these effects, including the SNS, the RAAS, and natriuretic peptides. High levels of angiotensin II contribute to endothelial dysfunction, mediates arterial remodeling, and is associated with end organ effects of hypertension. Okay, now with secondary hypertension, this is caused by underlying disease process that raises peripheral vascular resistance or cardiac output. Need to identify and remove the underlying issue before permanent structural changes occur. Complicated hypertension, chronic hypertension damages the walls of the systemic blood vessels. And there could be malignant hypertension, which this is a rapidly progressive hypertension in which the diastolic pressure is usually greater than 140 and can cause encephalopathy. Now, on the other end, we have hypotension or orthostatic postural hypertension. There's a decrease in systolic and diastolic arterial blood pressure on standing. The systolic pressure decreases at least 20, and the diastolic decreases by at least 10 within 3 minutes of the person standing up. This can be arteriolar, venular, or mixed. Compensatory changes during standing normally increase the sympathetic activity mediated through stretch receptors in the carotid sinus and aortic arch. And compensatory changes are not effective with orthostatic hypertension, so the body's not compensating here. This can be considered acute or chronic. Acute, there's altered body chemistry, drug action, prolonged immobility, starvation, physical exhaustion, or conditions that produce volume depletion or venous pooling in the lower extremities that can all lead to acute hypotension. Chronic, this could be secondary to a specific disease, or it can be idiopathic or no known cause. Patients may have dizziness, blurring or loss of vision, syncope, or fainting. Aneurysms, this is a localized dilation or outpouching of a vessel wall or cardiac chamber. A true aneurysm involves all 3 layers of the arterial wall. And the false aneurysm, there's extravascular hematoma that communicated with the intravascular space. This can happen with arteriosclerosis and hypertension. Occurs most commonly in the thoracic or abdominal aorta. The aorta is particularly susceptible due to constant stress on the vessels and absence of the vas vasorum in the media layer. Clinical manifestations are going to depend on where that aneurysm is located. An aneurysm in the heart may cause dysrhythmias, heart failure, or embolism. Aortic aneurysm is often asymptomatic until it ruptures, but it is sometimes found in routine clinical exam. Thoracic can cause dysphagia and dyspnea. This can be diagnosed with ultrasound, CT, MRI, or angiography. And it's important to maintain low blood volume and low blood pressure to decrease mechanical forces. If there is aortic dissection, this is a surgical emergency. And this diagram is showing the outpouching there of the abdominal aneurysm. Embolism, this is obstruction of a vessel by an embolus, causes ischemia or infarction in tissues distal to the obstruction because it's not getting any oxygen flow there. Different types, there can be a thromboembolism, vascular obstruction resulting from a dislodged thrombus, can occur with valve disease and dysrhythmias. An air embolism, room air enters the circulation, usually through an IV line, and there's large amounts of nitrogen in the air, and that can't resolve rapidly enough. And this can be caused also by trauma to the chest wall. Amniotic fluid embolism, there's great intra-abdominal pressure during labor and delivery, and this may force some of that amniotic fluid into the bloodstream through the highly vascular uterine wall. Bacterial embolism, isolated bacteria alone do not cause an embolism, but aggregates of the bacteria can be large enough to cause an embolism. And this is a particular risk with subacute bacterial endocarditis. A fat embolism can occur with trauma to the long bones. And there can be foreign matter that enters the bloodstream during trauma or through IV or an intra-arterial line that can cause a foreign matter embolus. Atherosclerosis, a form of arteriosclerosis in which thickening and hardening of vessels are caused by accumulation of lipid-laden macrophages within the arterial wall, which leads to the formation of a lesion called a plaque. And here you can see the plaque buildup starting there. This is not a single disease, but a pathological process that can affect vascular systems throughout the body, resulting in ischemic syndromes. It's an inflammatory disease that develops and proceeds in the presence of elevated plasma cholesterol levels. Innate and adaptive immunity play a role in the development and progression of atherosclerotic lesions. There's injured endothelial cells, and they're unable to make the normal amount of vasodilating cytokines. So we have endothelial injury and dysfunction leads to a fatty streak, which leads to a fibrotic plaque, and then a complicated lesion. Clinical manifestations, there's going to be signs and symptoms from inadequate tissue perfusion because of obstruction of vessels that supply them. We can have partial obstruction, such as transient ischemic events, or obstruction such as in the brain, which can lead to a stroke. Evaluation, we want to do a health history on the patient, a physical exam, check for bruits in those blood vessels, look at the labs, what are the lipids, the glucose, the CRP, can do an X-ray, EKG or ECG, ultrasound, nuclear scanning, CT, MRI, or angiography can all be done to detect for atherosclerosis. Treatment, detecting and treating preclinical lesions with drugs aimed at stabilizing and reversing plaques before they rupture. We want to treat this before it becomes a big problem. Oops, I just went too far ahead. Let's see where we're at. Peripheral artery disease. Atherosclerotic disease of arteries that perfuse limbs, especially the lower extremities. Prevalence, this increases with age and is disproportionately affects Blacks, smokers, and those with diabetes. Patient may have intermittent claudication. There's gradually increasing obstruction to the arterial blood flow of the legs, which can cause the patient to have pain with ambulation. Evaluation, we want to check for bruits, do the ankle brachial index. We can do a non-invasive Doppler measurement of blood flow. Treatment is going to be with antiplatelet or antithrombotic medications, aspirin, or these other listed here, some cholesterol lowering medications, and exercise rehab. Coronary artery disease, the most common cause of coronary artery obstruction is atherosclerosis. CAD diminishes myocardial metabolism to cause ischemia, and the cells are temporarily deprived of blood supply. Acute coronary syndrome, persistent ischemia, or the complete occlusion of a coronary artery. There can be infarction, which is irreversible myocardial injury. It's often a fatal event or a heart attack. Approximately 7% of the US population over 20 years of age has coronary artery disease. We have non-modifiable and modifiable risk factors. Non-modifiable, advanced age, male gender, or postmenopausal women, and those with a family history of coronary artery disease. Modifiable risk factors, dyslipidemia, hypertension, cigarette smoking, diabetes and insulin resistance, obesity, sedentary lifestyle, or an atherogenic diet. Dyslipidemia, lipids, these are required by most cells for manufacture and repair of plasma membranes. They manufacture essential substances as bile acids and steroid hormones, and most body cells can manufacture cholesterol. When we have dyslipidemia, there's abnormal concentrations of serum lipoproteins. Genetic and dietary factors are involved with dyslipidemia. Familial dyslipidemia, dyslipidemias, genetic defects that cause abnormalities in lipid metabolizing enzymes and abnormal cellular lipid receptors. Systemic disorders associated diabetes, hypothyroidism, pancreatitis, and renal nephrosis. We have the LDL or low density lipoprotein. Increased LDL is a strong indicator of coronary risk. LDL is responsible for delivery of cholesterol to the tissues. We have HDL, low levels are a strong indicator of coronary risk. The HDL is responsible for reverse cholesterol transport, in which it returns excess cholesterol from the tissues to the liver, binds to hepatic receptors, and processed and eliminated as bile or converted to cholesterol-containing steroids. HDL can remove excess cholesterol from the arterial wall. Myocardial ischemia, MI develops if supply of coronary blood cannot meet the demands of the myocardium for oxygen and nutrients. Most common cause of decreased coronary blood flow and resultant myocardial ischemia is atherosclerotic plaques in coronary circulation. These unstable plaques are prone to ulceration or rupture, which leads to platelet adhesion and thrombus formation. Thrombus formation can suddenly cut off blood supply to the heart muscle, resulting in acute myocardial ischemia. And if obstruction is not reversed rapidly, the ischemia progresses to infarction. Myocardial cells become ischemic within 10 seconds of coronary occlusion. So this happens pretty rapidly. After several minutes, the heart cells lose the ability to contract and cardiac output decreases. Ischemia causes conduction abnormalities that lead to EKG changes and may initiate dysrhythmias. Stable angina. This is a chronic coronary obstruction that results in recurrent, predictable chest pain. Prinzmetal angina, which is an abnormal vasospasm of coronary vessels that results in predictable chest pain. So with Prinzmetal, that's where you're having that vasospasm that's causing that chest pain. Silent ischemia, the myocardial ischemia that does not cause detectable symptoms. Obviously could be very dangerous. Evaluation, we're going to look for tachycardia, look for extra heart sounds such as gallops and murmurs. Is there pulmonary congestion that can indicate impaired left ventricular function? Xanthelasmas, which are small fat deposits around the eyelids. And the arcus senilis of the eyes, which is a yellow lipid ring around the cornea. And look for peripheral or carotid buoys. An ECG can give an indication of which coronary artery is involved, and stress radionuclide imaging can be used as well. Treatment is to increase delivery of oxygen by improving coronary artery blood flow, and diet, exercise, and risk reduction are part of that treatment plan. Hypertrophic cardiomyopathy, two major causes of thickening of the myocardium. Hypertrophic obstructive cardiomyopathy. This is the most common inherited defect. Autosomal dominant inheritance. And there's thickening of the septal wall, collagen deposition, altered contractile proteins, and myocytes. Patient may have angina, syncope, palpitations, symptoms of MI, and left heart failure. Diagnosis can be done with the aid of echocardiography and cardiac catheterization. Risk prevention, there's a risk for ventricular arrhythmias and sudden death. Treat with beta blockers of verapamil, or they may need surgical resection. Hypertensive or valvular hypertrophic cardiomyopathy. There's an increased resistance to ventricular ejection commonly seen in hypertension or valvular stenosis. Hypertrophy of myocytes is an attempt to compensate for increased myocardial workload. Patients are often asymptomatic or may have angina, syncope, dyspnea on exertion, palpitations, or extra heart sounds and murmurs. Disorders of the endocardium, valvular dysfunction. Endocardial damage can be congenital or acquired. With acquired, there's inflammatory, ischemic, traumatic, degenerative, or infectious alterations of valvular structure and function. Left heart valves, the mitral and aortic, are more commonly affected. The valvular stenosis, the valve orifice is constricted and narrowed, impeding forward flow of blood and increasing workload of the cardiac chamber proximal to the diseased valve. Valvular regurgitation, the valve leaflets fail to close completely and cause regurgitation of blood. During systole and diastole, some blood leaks back into the chamber. Valvular regurgitation increases the volume of blood the heart must pump and increases the workload of the affected heart chamber. Valvular dysfunction stimulates chamber dilation and/or myocardial hypertrophy. Stenosis, we can have aortic stenosis. This is the most common valvular abnormality. Most common causes are congenital bicuspid valve, calcific germination related to aging, inflammatory damage caused by rheumatic heart disease can all lead to aortic stenosis. Mitral stenosis impairs flow of blood from the left atrium to the left ventricle, and the most common cause is from acute rheumatic fever. Heart failure, pathophysiological condition in which the heart is unable to generate adequate cardiac output such that there is inadequate perfusion of tissues or increased diastolic filling pressure of the left ventricle or both. Risk factors for ischemic heart disease and ischemic heart disease and hypertension can lead to heart failure. Other risk factors: age, obesity, diseases such as diabetes, renal failure, valvular heart disease, cardiomyopathies, myocarditis, and congenital heart disease. Left heart failure, CHF, congestive heart failure. There's reduced ejection fraction or systolic heart failure, or heart failure with preserved ejection fraction. Heart failure with reduced ejection fraction, the EF is 40%, and the inability of the heart to generate adequate cardiac output to perfuse the vital tissues. Myocardial infarction is the most common cause of decreased contractility. And it's a complex constellation of neurohumoral, inflammatory, and metabolic processes. Evaluation, we're going to look for dyspnea, orthopnea, cough of frothy sputum. The patient may have decreased urine output, edema, pulmonary edema. There can be cyanosis, inspiratory crackles, pleural effusions. Patient may have hypotension or hypertension, an S3 gallop, and underlying coronary artery disease and hypertension need to be evaluated for. EKG, serum troponin, chest X-ray, and a heart cath may all need to be done as diagnostics. Management, interrupting the worsening cycle of decreasing contractility, increasing the preload and increasing afterload, as well as blocking neurohormonal mediators of myocardial toxicity. Diuretics reduce preload and are the mainstay of therapy. ACE inhibitors reduce preload and afterload, and beta blockers, salt restriction, loop diuretics, and aldosterone blockers may all be used. With right heart failure, it's the inability of the right ventricle to provide adequate blood flow into pulmonary circulation at normal central venous pressure. This most often results when there's left heart failure. Treatment relies on management of the left ventricular dysfunction. And when right heart failure occurs in the absence of left heart failure, it's usually due to pulmonary hypertension, which can be seen with COPD, cystic fibrosis, or ARDS, or adult respiratory distress syndrome. Dysrhythmias, arrhythmias are also called dysrhythmias. These are disturbances of heart rhythms. They range from occasional missed or rapid beats to serious disturbances that impair pumping ability of the heart, contributing to heart failure and death. These can be caused by either an abnormal rate of impulse generation by the SA node or other pacemaker, or abnormal conduction of impulses through the heart's conduction system. There's tables in the textbook that have more on dysrhythmias. Okay, we'll look at some alterations of cardiovascular function in children. The development of the cardiovascular system. Most of the cardiovascular development occurs between 4 and 7 weeks gestation. Embryology, there's cardiogenesis that begins approximately 3 weeks of gestation. By the 4th week of gestation, there's cardiovascular septation, ventricular development, aortic arch evolution, and circulation begins. Cardiac septation, there's endocardial cushions, which are instrumental in closing the lower portion of the atrial septum, dividing the atrioventricular canals, and forms the upper portion of the interventricular septum. Foramen ovale is a non-fused septum. An ostium secundum, it allows for right to left shunting of fetal circulation. The fetus receives blood carrying oxygen and nutrients from the placenta, and the brain and coronary arteries receive the blood with the highest oxygen concentration. Transitional circulation. At birth, a series of circulatory changes occur that affect blood flow, vascular resistance, and oxygen tension. Most important change is the shift of gas exchange from the placenta to the lungs. Alterations in pressure and volume of blood flow through the heart chambers functionally close the ductus arteriosus, ductus venosus, and the foramen ovale. Decrease in pulmonary vascular resistance and increase in systemic vascular resistance lead to changes in size and shape of the heart chambers. Closure of fetal shunts begins once the umbilical cord is clamped when the baby is born. Congenital heart defects, these are the leading cause of death in the first year of life, except for those that are born prematurely. There's 35 documented types of congenital heart defects, and the underlying cause is only known in about 10% of the cases. There's prenatal, environmental, and genetic factors involved with congenital heart defects. Prenatally, some issues can be a mom who has rubella, mom who has an insulin-dependent diabetes, alcoholism, or advanced age over 40. Drugs during pregnancy, such as thalidomide, lithium, phenytoin, and warfarin, can all cause some issues. Genetic, there can be chromosomal aberrations. About 50% of infants with trisomy 21 have a congenital heart defect as well. And these are classified as lesions increasing pulmonary blood flow, lesions decreasing pulmonary blood flow, obstructive lesions, or mixing lesions. That's all I'm going to cover on the cardiovascular system. Please let me know if you have any questions. Please keep in mind that I've only covered a certain portion of these chapters, and students are responsible for reading and reviewing the entirety of these chapters. Thank you all and have a great day.